seen, just have a 1 minute quick recap. First, we saw about this bedaquiline. What is the mechanism of action? By inhibiting ATP synthesis, QT prolongation, you should be remembering. Then liver hepatitis, you should be remembering. Delamanid, it produces a nitric oxide, poisons the bacilli, bactericidal. This also has least drug interactions. Short oral bedaquiline regimen, just remember the drugs in the regimen. And the exclusion criteria, most important, the 5 exclusion criteria you should be remembering. Next, those will be the inclusion criteria for longer oral regimen. This you should be knowing it. Next, the chart, how to follow the shorter oral and shorter injectable. In injectable, what we do? Since bedaquiline is not available, bedaquiline we remove it and we add amikacin or kanamycin. Same thing, same monthly schedule we will be following, same indications and same contraindications. Next, we saw longer oral regimen, group A, B, C, depending on the potency. Remember, best friends in line, close try to cross a dams, yet to pass, emergency. Okay, rules 18 to 20 months we will be giving, and no separate intensive and continuation phase we will be giving for 18 to 20 months. And all side effects of linezolid we saw: optic neuritis and peripheral neuropathy, anemia, thrombocytopenia, myelosuppression, you should be remembering. Okay, yes. Next, we saw the pregnancy management, MDR-TB. If it is less than 20 weeks, you must advise MTP, and after MTP, start shorter oral bedaquiline regimen. Hello friends, so today we will see the treatment aspects of drug resistant tuberculosis. So as we had discussed in the previous video, just brush up the definitions. First thing, the first line ATTs, HRZE, isoniazid, rifampicin, pyrazinamide, ethambutol. If the resistance is to one among the 4 agents, only one, then we call it as monoresistant tuberculosis. If it is specifically to rifampicin, then we call it as rifampicin resistant tuberculosis. If it is more than or equal to 2 out of the 4, then we see whether the resistance is involving both H and R. If it is both H and R, then we call it as multi-drug resistant tuberculosis, MDR-TB. If it is not both H and R, then we call it as polydrug resistant tuberculosis. And then we see resistance to fluoroquinolones. If it is present, then we call it as pre-XDR. If resistance is also due to group A drugs like linezolid or bedaquiline or both, then we call it as extreme drug resistant tuberculosis, XDR. Okay, so this basic definition you should be knowing. So now we will be seeing the treatment regimen for each part of tuberculosis, and then we will see in special situations how to handle the management. Yeah, so this is a short mnemonic to remember the regimen for all drug resistant tuberculosis. This is group A drugs are the most potent group, then comes group B, then comes group C. So group A, best friends are in a line, they are giving a close try to cross a dam. Okay, dam, they are yet to pass this dam and it's an emergency for them, or else they will be killed by the demons. Okay, so here group A, best friends, B, bedaquiline, F, fluoroquinolone, L, linezolid. Close try, clofazimine, cycloserine, triterrazidone. Next, dams, D, delamanid, A, M, amikacin, Z, pyrazinamide, yet to pass, so ethionamide, pass, paraaminosalicylate acid, and emergency, E, ethambutol, MER, meropenems. Okay, just remember the same order. This is the replacement sequence. You will be understanding it further. So this is the whole general groups of drugs used in drug resistant tuberculosis. Now let's see the most important drugs, the most latest developed drugs in this regimen. 2 drugs, one is bedaquiline, the another is delamanid. So what is this bedaquiline? See, this drug, what it does was, this is the TB bacilli trying to build the cell wall using mycolic acid. So it needs energy, which is the ATP. The mycobacterial ATP synthase is the enzyme which provides energy, ATP, for the bacilli to build its cell wall, which is mycolic acid. So this bedaquiline, what it does is, it inhibits this mycobacterial ATP synthase, leading to reduction in ATP, and this cell wall synthesis damage, leading to a bactericidal effect. Okay, so it's highly bactericidal. Next, A for, you can remember B for bactericidal, A for ATP synthase inhibition. Next, beta. When you will eat beta? After food. Okay, so after food, if you eat bedaquiline, this will increase the absorption of the drug. Okay, next is Q. Q comes QT prolongation. This most important side effect of bedaquiline, QT interval, which is the start of Q to the end of T wave. This will constitute a QT interval. We call it as prolonged if it is more than 450 milliseconds in male and 470 milliseconds in females. And also always you should check for the electrolyte abnormalities which also cause QT prolongation. Why? Because this QT prolongation, if it is happening, then that will lead to development of torsade de pointes, okay, ventricular fibrillation and torsade de pointes and sudden cardiac death. So the electrolytes causing prolongation of QT interval, three things: potassium, calcium, magnesium, hypokalemia, hypocalcemia, hypomagnesemia. Along with this bedaquiline, if you give, they have high risk of sudden cardiac death. So only a baseline ECG is necessary with QT prolongation, QT interval calculated. Then along with it, check for the electrolytes also before starting a patient on bedaquiline. And other drugs, ATD drugs which cause QT prolongation, you should be remembering: first is bedaquiline, next is your fluoroquinolones, which is moxifloxacin, having maximum QT prolongation. Next is your delamanid and the clofazimine. All these drugs can cause QT prolongation. Okay. Next, L, you can take it for liver toxicity. It causes metabolism is through liver only and causes hepatitis. So in case of hepatitis, you should always check the liver enzymes before giving bedaquiline. Okay. So this is the way to remember all the points about bedaquiline. Next drug is this delamanid, which is a prodrug which on activation produces nitric oxide. What this nitric oxide does is this poisons the bacilli and it is a highly effective bactericidal drug. Okay, so this is also a bactericidal drug. It also inhibits the cell wall synthesis and also it poisons the bacilli by production of nitric oxide. Next is, it is a group C drug. Actually, it is not still available in so many centers in India. So it is also used as a reserve drug. Only when it is necessary, we will be giving it. Next is, the best part of delamanid is it has very less drug interactions. Okay, very less amount of side effects also. It has a minimal QT prolongation, but not that much compared with bedaquiline. Okay, yeah. So now let's see this shorter oral bedaquiline regimen. So among the group A drugs, two drugs best friends, bedaquiline and fluoroquinolones, which are levofloxacin. Next is, among close friends, we take clofazimine. Next is since I told delamanid is reserve drug, we are not using upfront here itself. We use all the other oral drugs like pyrazinamide, ethambutol, ethionamide and high dose isoniazid. Okay, so now you should know where you should give this patient and where you should not give. The exclusion criteria, this is most important. See, as I told, bedaquiline is contraindicated in children less than 5 years. So you can't give this regimen for children less than 5 years. And also, you know that ethionamide and fluoroquinolones, these are contraindicated in pregnancy. Ethionamide is teratogenic and actually it is teratogenic in the first trimester and it causes hypothyroidism if you give the drug in the second trimester. You can't give ethionamide till 32 weeks of pregnancy. Okay, so you can't give this drug in this regimen in pregnancy. Next contraindication is lactation, obviously. Next is two contraindications you'll be knowing: extensive TB and severe extrapulmonary TB. Extensive TB means bilateral lung disease with bilateral cavities. Okay, and severe extrapulmonary tuberculosis, like it can be miliary tuberculosis or all extrapulmonary tuberculosis in children except lymph nodes, and like CNS tuberculosis, TB meningitis, all this will come under this severe extrapulmonary tuberculosis. So, and drug intolerance to this bedaquiline regimen. So all these are exclusion criteria for your bedaquiline regimen. So in these situations, what you should go for? You should go for longer oral MDR regimen. We will be seeing it later. Okay, these are the indications for that longer regimen. And shorter regimen, these are the contraindications for shorter regimen. Children less than 5 years, pregnancy, lactation, and severe extrapulmonary TB and extensive tuberculosis, bilateral cavitary tubercular disease. Yes. Next is inclusion, where you should treat. In any MDR TB or rifampicin resistant TB, and you are giving a fluoroquinolone in this regimen, so obviously it should be fluoroquinolone sensitive. Then you are giving high dose isoniazid acid in this regimen. So two mutations which can cause isoniazid acid resistance are, one is CATG and INHA. So if either one of the mutation is there, then you can give this regimen. High dose isoniazid acid will work. If it is both, then you can't give it. Okay, so these are the inclusion criteria. So in these patients, what is the characteristic feature is, they are like, this regimen is for a very shorter duration, for a 9 to 11 months. Yeah, we will see the scheduling of these drugs, how to give monthly, each month how to proceed with this regimen. First, bedaquiline, how to give these drugs are intensive phase 4 months. Just close your eyes and give all these drugs for 4 months. At the end of 4th month, you should be doing a microscopy, sputum microscopy, and you should be checking for the drug susceptibility testing also. If in sputum microscopy, if it has converted, meaning it has converted from positive, AFB positive to AFB negative, then what you can give is, we told bedaquiline can be given till 6 months. So give bedaquiline since till 6 months and stop it. And ethionamide and high dose isoniazid acid, when you get negative result, sputum negative result, stop that time itself, because ethionamide has a high amount of side effects. So better stop at 4th month itself. Okay, and then this is the intensive phase. Next comes the continuation phase. Other 4 drugs you can give for the continuation phase of 5 months. 5 months CP, continuation phase, is fixed for this regimen. So 9 months MDR treatment regimen is completed. Okay, yes. Next question comes, what if the sputum turns out to be positive at the end of 4th month? Then what you will do? What I can, bedaquiline maximum duration is only 6 months, so give it till 6 months. Then what you can do is, you should check the patient and you should send the sputum sample for drug susceptibility testing and line probe assay to check for further development of any resistance for these drugs or not. Okay, because still it has not turned out to be negative. Then what you can do is, obviously you can continue these drugs, and at the end of 5th month and 6th month, you will be repeating the same test again. If it turned out to be negative, no problem. Just give this stop at the 6th month. You should stop bedaquiline, ethionamide, isoniazid acid. Just give those 4 drugs again. 5 months continuation phase is fixed. Okay, fixed till 11th month. Give it, then stop this regimen. Okay, wherever point, if you find resistance to any of these drugs, and you should immediately go for this LPA, and if you have found resistance, then shift to longer oral regimen. We will be discussing later. This you should be knowing. So shorter oral bedaquiline regimen, intensive phase is 4 to 6 months. 6 months for bedaquiline, 4 months for isoniazid acid and ethionamide if it is sputum negative. Or if it continue, you can extend this intensive phase for ethionamide and isoniazid acid if it is sputum positive at the end of 4th month. And CP, continuation phase, is fixed for 5 months. Total duration is 9 to 11 months. This chart you can remember for treatment. Okay, yes. Next comes our shorter injectable containing regimen. Now next the question comes, where I should go for injectable containing regimen. See, the point is, this bedaquiline is still not widely available in many of the centers in our country. So till it becomes available widely, okay, so injectable bedaquiline is not available, so only this regimen was framed. So bedaquiline is obviously not in this regimen. Next is fluoroquinolone. We are giving the maximum potent fluoroquinolone, moxifloxacin, since bedaquiline is not available. Next is clofazimide. Next is pyrazinamide, ethambutol, high dose isoniazid acid, and ethionamide. All the 4 drugs which we are using in shorter oral bedaquiline treatment. Same 4 drugs. Since it is injectable regimen, what is injectable? We were discussing it is amikacin or kanamycin. This you should be using. Bas. So indications are same thing. MDR or rifampicin resistant TB only, and it should be sensitive to fluoroquinolone, and the patient should be aminoglycoside sensitive. So here only you can use this regimen. So here what are the contraindications? Same contraindications as bedaquiline regimen. So what are the contraindications? Since bedaquiline is not there, children less than 5 years is not a contraindication here. And contraindicated in all pregnancy, obviously because aminoglycoside and fluoroquinolones are contraindicated in pregnancy. Ethionamide is teratogenic and cause hypothyroidism in pregnancy, so it is contraindicated in lactation also, and severe extrapulmonary TB and extensive TB. So all this contraindication which we saw for short oral bedaquiline regimen. So next we will see the monthly schedule for injectable regimen. So here also same thing, give these drugs blindly for 4 months. All these drugs give for 4 months. Daily we will be injecting this patient with condamycin or amikacin. So only we should have a baseline audiometry done before starting the patient on this injectables. So then what you should do is same thing. You should check for sputum microscopy at the end of 4th month. If it is negative, what you can do? You can stop all the injectables. You can stop ethionamide and high dose isoniazid acid like the short oral bedaquiline regimen. We stopped at the 4th month. Here also you can stop. Then what you can do is other drugs you can continue same thing for 5 months, like how we continued in bedaquiline regimen. 5 months continuation phase. It is fixed, similar to that regimen. Okay. Yes. So next is, if the sputum turned out to be positive, then what you will do? You will extend this intensive phase again to 6 months. Till 6 months we will be extend this phase, and we will also work up for further development of any resistance, like LPA studies we will do, so that any resistance are developed, then we will shift the patient to longer oral MDR regimen. Okay. Then it's in extension phase, there is no need to give daily injectable. You can give 3 times per week, and after 6 months you can stop the injectables, ethionamide and isoniazid, like how we followed previously. And same thing, continuation phase 5 months. All those 4 drugs continue for 5 months. So total duration is obviously same thing, 9 to 11 months. Okay. Yes. Next comes our longer oral regimen. This is where our mnemonic comes into play. So here we have most potent group of drugs which are the best friends in line, which is bedaquiline, fluoroquinolone, linezolid. And next, group B, clofazimine, cycloserine, terazolam. Group C, DAMS yet to pass emergency. Delamanid, amikacin, pyrazinamide, ethionamide, pass, ethambutol, meropenem. So this is the order of potency. This is how you should replace some drug if some drug doesn't work in this regimen. Like the best ideal combination for longer oral regimen is, what are the most potent drugs? Group A. Include all the 3 drugs in group A and include 2 drugs in group B. 5 drugs if you include, and if it is 3 from group A and 2 from group B, then it's the most ideal combination. Okay, this is the best ideal combination. If you find there is a resistance to fluoroquinolone or resistance to linezolid, then what you can do? You can add some drug from group C. How to add? What is the sequence? This DAMS yet to pass emergency. First delamanid, next amikacin, next pyrazinamide, like that, in the same order you should be adding. Okay. Yes. So longer oral regimen, group A, B, C you should be knowing. So how to rules is, total duration is 18 to 20 months compared with 9 to 11 months for shorter regimen. So here there is no separate intensive phase, continuation phase, just give all the drugs for 18 to 20 months. Group A, all 3, and group B, 2 drugs are the best ideal combination. Give at least for 6 to 8 months. Then what you can do is 5 drugs for 6 to 8 months followed by 4 drugs in the last 12 months. This is the best ideal combination. So yes, monthly schedule is ideal combo. Group A, bedaquiline, levoflox, linezolid. Group B, clofazimine, cycloserine. So this we are giving for a maximum period of 6 to 8 months. Same thing, at the end of 6th month here we will be doing this sputum microscopy. If it is negative, continue for 8th month, then stop bedaquiline. I have told bedaquiline maximum duration is 6 months. Only in longer oral regimen we extend this to 8 months. Okay, and after 8 months stop it. So other drugs you can continue till 18 to 20 months. This is the proper duration of longer oral MDR regimen. If there is any resistance, start replacing in this order what I taught. Next, just know some features of linezolid. How to remember the features of linezolid? See, line. What is the meaning of line? IV lines. Like IV, whatever drug you inject is equal to oral. Meaning oral linezolid has 100% bioavailability. This is the best part of linezolid. You can give oral linezolid capsules. Then Z for cheese reaction. If you give with monoamine oxidase inhibitors, it will cause cheese reaction. Next is, you should be knowing, it inhibits mitochondrial functioning. In mitochondria, this TCA cycle functions. If this mitochondrion is inhibited, TCA cycle won't be functioning adequately. So what won't happen? Whatever pyruvate which is entering into the TCA cycle won't be processing forward. So what will happen to pyruvate? They will be shifted to anaerobic metabolism and they will produce lactic acid. And this anaerobic metabolism will obviously produce less number of ATPs. So one is, it can cause lactic acidosis by shifting this process to anaerobic metabolism. So patient will be having lactic acidosis. And next process is, this mitochondrium which will be providing maximum ATP. There are cells which require lots of ATPs for its constant functioning. Two things, one is your neurons and the other is bone marrow. So since if peripheral neurons are inhibited, so this will cause peripheral neuropathy. It's a great side effect. It's most important side effect of linezolid. Peripheral neuropathy as well as your optic nerve can also be involved, causing optic neuritis. One ATT causing optic neuritis. Another, we would have been studying ethambutol, and this also you should know, linezolid. Optic neuritis and peripheral neuropathy. Next, L for lactic acidosis, O for optic neuropathy. Then it causes myelosuppression. The mitochondrial functioning other than the neurons is the bone marrow. So if bone marrow is inhibited, that will cause myelosuppression. That will cause anemia, thrombocytopenia and leukopenia in rare cases. But anemia, thrombocytopenia should be known. So these are the side effects and the points to know with respect to linezolid. Okay. Now next comes how to manage MDR-TB in pregnancy. Do you know that MDR-TB itself is a contraindication for pregnancy, where you should counsel the woman for medical termination of pregnancy, MTP. So how to follow the protocol? First, see the duration of pregnancy. If it is in the first trimester, if it is in the less than 20 weeks, what you can do is you must advise MTP. Okay, because the treatment will be effective only if you include those drugs which are teratogenic. Okay, so you must advise MTP. Then after MTP you should start shorter oral BEDAQUILLINE regimen. This you should know. Next, if the patient is not willing for MTP, or if the patient's period of gestation is more than 20 weeks, what you can do? See, there is a rule which we discussed previously. Ethionamide can't be given till 32 weeks of pregnancy, because it is teratogenic in the first trimester, and second trimester if you give it will cause hypothyroidism. So till 32 weeks, what you can do is you can't give ethionamide. So what regimen you can follow? You can obviously follow the longer oral MDR regimen. There ethionamide is not there. We can include group A 3 drugs and group B 2 drugs, and we can finish it off. So if it is less than 32 weeks where you can't give ethionamide, they go for longer oral MDR regimen. In more than 32 weeks, there is no problem with giving ethionamide. Still, it should be a decision taken between the pulmonologist as well as the obstetrician. They should decide and they should plan what drug regimen should be given, BEDAQUILLINE or longer oral. But remember, BEDAQUILLINE can be given if it is crossed 32 weeks. Okay, this is how you should manage MDR-TB in pregnancy. Next, this is the famous BPAL regimen under research now. Actually, even in XDR-TB, it has proved 90% successful. And also BPAL, BEDAQUILLINE for 6 months. Pritomanid, which is a brother of DELAMANID only, it is given for 6 months plus 2 weeks, 26 weeks. And linezolid 6 months. All just give for 6 months. Only 2 weeks extra pritomanid you will be giving. This is the BPAL regimen. This is the last resort. If nothing works in longer oral regimen, then you will go for BPAL regimen. This is still under research, not followed this thing. And obviously you should hospitalize the patient for the first 2 weeks. Okay, yeah. So coming on to the last regimen, which is what if the patient is sensitive to rifampicin but resistant to isoniazid acid or polydrug resistant TB. How do you manage? Since the patient is sensitive to rifampicin, you can give rifampicin, pyrazinamide, ethambutol, Plus you can have the group A drug, which is levofloxacin. Okay, poly drug treatment, you can give levofloxacin. Duration is 6 months or 9 months. Same thing here also, at the end of 4th month we will be doing sputum microscopy. If it is positive, give for 9 months. If it is negative, give for 6 months. And you should work up for LPA studies to find further development of resistance. If any resistance develops, obviously you should be replacing, like next you can add linezolid, clofazimine, all these drugs you can have one by one. Okay, depending on the sensitivity. And also if the patient is extrapulmonary tuberculosis, extensive tuberculosis, here better give it for 9 months. Okay, yes. So this is it done with the entire regimens in the treatment of tuberculosis, pregnancy, how to manage, and this is the drugs we have seen, major things to remember. Okay, so what all we have seen, just have a 1 minute quick recap. First we saw about this bedaquiline. What is the mechanism of action? By inhibiting ATP synthesis, QT prolongation you should be remembering. Then liver hepatitis you should be remembering. Delamanid, it produces a nitric oxide, poisons the bacilli, bactericidal. This also has least drug interactions. Short oral bedaquiline regimen, just remember the drugs in the regimen. And the exclusion criteria, most important, the 5 exclusion criteria you should be remembering. Next, those will be the inclusion criteria for longer oral regimen. This you should be knowing it. Next, the chart, how to follow the shorter oral and shorter injectable. In injectable, what we do, since bedaquiline is not available, bedaquiline we remove it and we add amikacin or kanamycin. Same thing, same monthly schedule we will be following, same indications and same contraindications. Next we saw long oral regimen, group A, B, C, depending on the potency. Remember, best friends in line, close try to cross a dams, yet to pass emergency. Okay, rules 18 to 20 months we will be giving, and no separate intensive and continuation phase we will be giving for 18 to 20 months. And all side effects of linezolid we saw: optic neuritis and peripheral neuropathy, anemia, thrombocytopenia, myelosuppression you should be remembering. Okay, yes. Next, without the pregnancy management, MDR-TB, if it is less than 20 weeks, you must advise MTP, and after MTP, start shorter oral bedaquiline regimen. If it is more than 20 weeks, if it is less than 32 weeks, where ethionamide can't be given, there you should go for longer oral TB regimen. And if it is more than 32 weeks, you can give both regimens depending on the decision between the obstetrician and pulmonologist. Okay, that's it. I hope it helped you. That's it. Do subscribe our channel for further videos like this, and do comment your opinions. Thank you.